Greetings, everyone, and welcome to this new version of the EAU webinars by the European School of Urology. And well, nowadays, you know that thanks to novel approaches and genomic stratification, we have entered into a new era where genitourinary cancers can achieve cure and long-term survivals without disease progression. Around 20% of patients with prostate cancer have germline or tumor mutations, and probably BRCA2 is the most common. And this webinar, it's about this, about the PARP inhibitors, and it's the second part of a webinar series that we have been doing during 2022. For this, we have two experts with us, Dr. Javier Puente, which I have the pleasure to work with in Madrid, and also Dr. Axel Messenburger for Germany. Having said this as an introduction, I will leave the floor to Javier Puente, who will start the presentation. Thank you very much. And once again, thanks to all our guests for being today with us.
Okay, thank you very much, Juan. Thank you for your kind introduction. I'm going to share my screen. Okay. So, well, good afternoon, everybody. I would like to begin by thanking all the organizers and the people from the European School of Urology for inviting me to this meeting, focusing the use of PARP inhibitors in prostate cancer. Well, my presentations will try to show the basic concept about the DNA alterations, and the title of this presentation is From DNA Damage Repair to the Homologous Recombinations Deficiency in Advanced Prostate Cancer. We try to make the things easier for the basic concept that could allow to use the PARP inhibitors in patients with prostate cancer. So I try to, okay, sorry. These are my disclosures. Well, as you can see in this slide, we know that a multitude of events occur daily that lead to DNA damage that require subsequent repair. The ability to repair correctly the DNA is crucial for cell survival and also to prevent malignancy. And we know that different sources could affect to the DNA, for example, the ultraviolet light, for example, the ionizing radiation, for example, chemical carcinogens. Obviously, at the end, the DNA replication is an error-prone process and which requires a highly proficient system to recognize these errors are properly, because the DNA damage is the major contributor of the carcinogenesis. And when this damage is not adequately repaired, can lead to the accumulations of mistake at the end, increase the risk of cancer. So the evolution have, make different systems to repair this DNA damage. And depending on the type of DNA damage, we have two different pathways to repair them. For example, the pathway to repair the single-strand DNA breaks. And on the other hand, we have a pathway and a system to repair the double-strand DNA breaks. Well, in this slide, you can see the pathway involved in the single-strand DNA repair system. As you can see, we have the pathway called the mismatch repair, and this pathway fixes small insertions and deletions occurring during the normal DNA replication. And the genes that have been involved in this mismatch repair system are very famous. For example, the MSA2, MSA6, MLH1, or PMS2, for example. And these genes could be affected in 1% for the patients with prostate cancer. The second pathway is called the nucleoside excision repair, and this system is activated to remove bulky DNA lesions and includes, for example, genes that describe like ARCC1 or ARCC8. And finally, the third pathway that could be remove the single-stranded DNA damage is the single-stranded break repair and rejoins broken strand during the base excision repair, and include these genes, for example, the PARP1, POLB, XRCC1, etc. In the other hand, we have pathways involved in the double-strand DNA damage repair, and includes the famous homologous recombination pathway, and includes, for example, genes like BRCA2, BRCA1, PALB2, or the non-homologous enjoining that repairs the DNA, creating selections, for example, with the involvement of ATM and another famous genes. So a varied number of DNA lesions can be formed by spontaneous single-strand breaks, for example, by any base modification. And the single-strand base breaks are very rapidly detected and bound by PARP1. PARP is a family of proteins that includes 17 different proteins, and in which PARP1 and PARP2 are involved in DNA repair. PARP1, as you can see in the slide, binds to the damaged DNA, and after a conformal changes, induce the PARylation and recruits proteins that induce the repair system. And at the end, once the repair system is finished, PARP1 is released from the DNA. The problem is when PARP1 is not correctly functioning, and when PARP1 is deficient, a single-strand break cannot be repaired, and during the process of the DNA replication, these single-strand alterations convert in a double-strand breaks. And the double-strand break repair needs this classic two system that we have talking before. And one of them is the homologous recombination. And the following the DNA double-strand break is detected and recruited by the ATM. And ATM induces a phosphorylation cascade, including BRCA1 and another genes, and at the end, repair the mate's original. So what is important from the perspective of prostate cancer? It is because in 2005, two groups described the concept of synthetic lethality. And this is an interaction between the PARP inhibition and the BRCA1 or BRCA2 mutation, suggesting a novel approach for treated patients with these alterations. And this is because in those situations where PARP1 is inhibited, for example, with the use of PARP inhibitors, and there is a deficit in the function of BRCA, DNA is not correctly repaired and lead to cell death. So synthetic lethality is a concept, is something to describe where either one of the two genes has a little effect on the cell, but the combinations of the deficiency in both hands can lead to cell death. So if we use a PARP inhibitors in a patient without a function in BRCA1, at the end, we suffer a cell death. So why is it important? It is because we know that some patients with prostate cancer have alterations in DNA repair genes. And initially, this was described in family with some members affected for prostate cancer. And this is something important because they have a lot of impact in the natural history of this disease. In this slide, you can see two different patients. In the top of the disease, in the top of this slide, you have a BRCA2 mutant tumor, for example. And in the bottom of the slide, we have a sporadic tumors. As you can see here, the BRCA2 mutant tumors are defined as a global genomic instability, a global hypomethylation up from the beginning of the disease. However, in contrast, patients with a sporadic tumor are more samples. And at the end of the disease, we can observe this global genomic instability and alterations in some genes. So as consequence, those patients with these alterations have a worse outcomes in terms of overall survival, cancer-specific survival, and metastasis-free survival. As you can see here, the classic studies from Elena Castro, and as you can see here, the 3, 5, and 10 years cancer-specific survival rate were significantly better in patients without DNA gene alterations than in patients with these alterations that have been treated with radical prostatectomy or with radiation therapy. And again, this is also important in the setting of the castration-resistant prostate cancer. But as you can see in the slide, patients with alteration in germline DDR alterations have a poor outcomes and a worse outcomes in terms of overall survival. Especially in Spain, for example, we have analyzed the impact of these alterations in patients with castration-assisted prostate cancer. The PRO-REPAIR-B was a multi-center prospective study that we have done in Spain with many centers, and tried to identify what is the impact of these alterations in these genes in the evolution of patients with prostate cancer. And as you can see here, patients with castration-assisted prostate cancer has a worse outcome compared with those patients without this alteration, as you can see in this slide. But these DNA repair genes not only have been described via germline route, but also have been described in tumor samples in patients with metastatic castration-assisted prostate cancer. And as you can see in the slide, coming from the genomic profiling of the metastatic castration-assisted prostate cancer, nearly 25% of all patients with metastatic castration-assisted prostate cancer have DNA repair pathway aberration. So these DNA repair alterations could be described not only in patients with localized disease at the beginning of the disease via germline route, as you can see here in the right part of the slide, that they have described in 80 to 10% of the patients, but also could increase to 25% in patients with metastatic disease in the setting of the metastatic castration-assisted prostate cancer. So it's very interesting to know what are the patients that are having these alterations that potentially could be treated with a PARP inhibitor in the setting of metastatic disease. As Sex will show later, the activity of different PARP inhibitors has been proven in multiple studies. However, something very important is how can we detect it properly, this population? And this is something controversial, because obviously some studies will be focused in the analysis of the tumor samples, and another trials will be looking for these alterations not only in tumor, but also, for example, in the analysis of the blood or via germinal route. As you can see here, this is the design of the PROfound trial that Axel will mention later. But something interesting is in this study, patients will select it based on the result of the Foundation 1 next generation sequencing test. And these tests have been done in tumor samples from the primary to the metastatic setting and identify alterations in any of these genes that have been described in the slide. In contrast, for example, in the Triton-2 study, an open-label single-arm study with rucaparib, the patients will be identified not only analyzing the tumor sample, but also doing central testing of blood and trying to identify alteration not only in tumor sample, but also in samples from blood. So what tests could be feasible for making these genomic alterations? How can we select it properly? Obviously, we can analyze the tumor tissue biopsy, analyzing the primary prostate tumor or the metastatic biopsies that we can obtain, or we can focus in liquid biopsy. For example, from the blood, we can analyze the germline DNA, or we can analyze the tumor-free DNA that we can observe in a liquid biopsy. For example, analyzing the circulating tumor DNA or the circulating tumor cells, so we can identify properly those patients. Something interesting in a practical point of view, if you try to identify correctly these alterations in a somatic route, identify these alterations, for example, in the analysis of the tumor sample, we have the experience with the PROfound study. And in the PROfound study, something interesting is that you can increase your success rate for the analysis of the tumor sample if you analyze newly collected samples compared with the archived tumor samples. We have more successful if you analyze metastatic tumor samples versus the primary tumor, and you are more successful rate if you analyze a short period of time in terms of the evolution of the disease compared with those samples that they are being obtained many years ago. As you can see here, the tumor testing success by the biopsy, you increase the success rate if you analyze, for example, the metastatic tumor coming from the visceral metastasis of the lymph node, compared with the primary tumor that there are a lot of stroma, or from the bone that we have problems with the calcification of the tumor samples. So if you analyze the tumor samples, you are going to increase your rate around 75% if you are analyzing the metastatic samples. But sometimes you have problems with the primary tumor, for example, or your samples are from many years ago. So in this case, can you perform a liquid biopsy? It could be feasible. And in this paper and work published by Simon Chowdhury, in the Triton 203 study, they have demonstrated the feasibility of next generation sequencing testing to identify patients with alterations in the homologous recombination repair genes with a high concordance. As you can see here, we can observe a 75% of concordance between the liquid biopsy and the tissue simple testing. So it could be interesting in patients that we can do or we can perform tumor analysis because of the screening failure, or we have a bad biopsy at the beginning, or less core samples affected. So it's less invasive, more sensitive, and a lower testing failure rate versus the tissue, and it could be interesting in some cases. More recently, we have a concordance of the damaged DNA repair genes mutations detected in primary prostate cancer and the metastatic tissue or cell-free DNA. And as you can see here, we have a high concordance with the novel strategy of identifications with liquid biopsy with greater than 85%. So it's very interesting to combine this tumor sample analysis with the liquid biopsies to increase the screening rates of this alteration. So we are distinguished between the germline testing, somatic testing, tumor samples, and liquid samples. So there's different concepts. We have a germline testing, and this slide is coming from Dr. Cheng about the advantage of doing this germline testing, because we can do on saliva, on blood, we can do during any point of the disease course, and may provide information about prognosis, and may provide life-saving information for blood relatives and families. However, the limitation of this germline testing will not identify tumor-only mutations, as we can observe in the castration-resistant prostate cancer, that they increase the alterations more than 25% of the patients and require more informed consent discussion and genetic counseling resources in the hospital. In contrast, the somatic testing can identify correctly the defect in tumor only that may be missed by germline only testing. We can do that on tissue biopsy or cell-free DNA in blood, for example, may provide information about prognosis, target therapy options, clinical trial that you can incorporate it. But a limitation of doing only somatic testing is that obviously repeat testing will be needed because many actionation mutations are truncal, and maybe at the end of the disease, we can observe another alterations. We don't have information about potential cancer risk to relatives. And so I think that it could be complementary, this testing. Finally, we have the possibility to making tumor biopsies. The advantage of these tumor biopsies are the tumor-enriched samples. We detect copy number changes. We can measure the tumor mutational burden. But the limitation is that we need a more involved procedure than blood draw. We have potential for inadequate tumor sample, more than 30% of testing failure rate, and more difficult to do serial samples, for example, because obviously the biopsy are difficult sometimes. The liquid biopsy can detect somatic mutation, are more common and less invasive. We have low testing failure rate, but potentially we have only fragmented DNA, and sometimes we have problems with the concept of clonal hematopoiesis of indeterminate potential and can cause interference with the cell-free DNA. And this is something complicated and not validated to detect homozygotic loss. So at the end, we have both alternatives to approach the definitions of patients that could be potentially treated with PARP inhibitors. So finally, take-home message. While BRCA2 germline deficiency is the most commonly homologous recombination repair deficiency in prostate cancer, and the inhibition of the single-strand damage by the PARP1 inhibition with patients with BRCA2 deficiency results in the concept of synthetic lethality. And this is very important for the cell death. So the identification of patients with damage defect repair deficiency by germline or somatic testing lead to a specific therapeutic development. And Axel will mention the new PARP inhibitor that could be an option in the treatment landscape of metastatic castration-resistant prostate cancer. Both genomic tumor and germline testing are important. Genomic or tumor somatic testing with a platform like the next generation sequencing or another platform could be used from the primary tumor to the metastatic setting. Obviously, you have to be cautious about the time from the primary tumor to the metastatic setting and try to obtain a good tumor samples to testing appropriately and consider the tumor testing earlier. Be proactive to looking for this alteration. And germline genetic testing will be necessary, and this is important for all men with family history and high-risk localized disease and metastatic prostate cancer, and will be in the same times to offer the genomic counseling. And that's all, Juan.
Thank you very much, Javier, for this overview on the DNA damage repair and the recombination deficiency in advanced prostate cancer. I would like to remind the attendees that you have a Q&A box where you can start asking questions to our speakers, but we will leave the discussion at the end of this meeting because all the lectures are related one to another. Now we'll give the floor to Dr. Messenburger, that he will talk about the actual evidence of PARP inhibitors in the treatment of prostate cancer. So Axel, the floor is yours.
Juan, thanks a lot. Thanks to you, to the organizers, to the EAU, to the European School of Urology, Evangelios, Beatzikos, and team for giving me the opportunity to speak on actual evidence for PARP inhibition for the treatment of prostate cancer. And I was lucky not to be chosen to cover the first topic. And I can only congratulate you, Javier, on really doing a perfect job. I haven't seen such a precise summary within like 20 minutes on this not too easy to digest topic. And I have to admit, I have to see it over and over. And as you just saw in about 48 minutes, you're able to see the talks again on demand on the ESUO and Euroweb page. So I think thanks again for setting the scene on the mechanism of action and how PARP is working and BRCA1, what BRCA2 alterations, what HRR alterations are. Here are my potential conflicts of interest, and most important for you, this activity is sponsored by AstraZeneca, but I wasn't influenced and there was no influential from the sponsor on my slides. In fact, it was homemade, as you will see in a while. On the other hand, the conflict I have to declare is that I'm one of the Triton investigators leading the Triton 2 and Triton 3 trial within steering committees, and was also involved in the Profound trial. So let me just triple divide those coming 20 minutes in state of the art, then a guidelines and practical guide to decide, and future combinations. And prostate cancer, you are probably all aware, but the number of patients predicted to die from prostate cancer is expected to double in the next 20 years. Men grow older and older due to demographic changes and better healthcare system worldwide. the 5-year survival rate for men with metastatic CRPC is about 30%. So this prognosis is much different what you learn from webinars here on locally advanced prostate cancer. We are speaking about deadly disease. We're speaking about a very, very palliative situation. And it has been shown by Dan George within the Flatiron Healthcare database that the survival of men with prostate cancer included in clinical trials is much better. It's about 3 years compared to about 2 years in real-world evidence. So the median OS of life-prolonging therapy was 23.7 months versus about just 1 year, 10.1 months with no life-prolonging therapy. So it's really like well invested. We have this data to really treat the patients first-line MHSPC, mCRPC, second, and if best, really using targeted therapy. So let's have a look at why only 1 in 2 patients will receive just one line of active therapy in mCRPC. And apology, look at those 2,559 patients included in the Flatiron database from mCRPC. 1,980 received first-line therapy, and then it divides up. Some received other care, died, and so eventually see how low the numbers are to third line, and it's 414 patients. So really there's an unmet need in therapy continuation, and there are multiple reasons, and we've just discussed some of the reasons last weekend in the beautiful city of Lugano in Ticino in Switzerland within the APCCC 22 meeting. It was very exciting discussing like the different landscapes and also the different healthcare environment. And I've learned from the American colleagues that even cost plays a role in a highly developed country like the US. So we have multiple trials investigating PARP inhibitors in prostate cancer. And this is just a snapshot, or maybe just like a vision of the largest trial that have been reported or that are ongoing and still awaiting data presentation at future conferences and well-known journals. So let's just move on to the next slide. And you might remember this. Javier has shown you that the 25% of men with mCRPC may harbor an HRR gene alterations. And then it comes down to mostly BRCA1 and BRCA2, which in fact is good for us as treating physicians because we know those are the ones where a PARP inhibitor works best. It's not the ATM, it's not the CHEK or CDK12, it's the BRCA. And that's why it's good to remember, we know the prognosis is worse, but we have a treatment that is really precise, a tailored treatment, a targeted treatment, a molecular-based treatment with a PARP inhibitor, as this excellently described by Javier just some minutes ago. But we also have to keep in mind, and that's why I think it's well invested, what we just saw from Javier, how difficult it can be to find out about the HRR status, if biomarker positive or negative, if it makes sense to invest in treatment with a PARP inhibitor. And you see here out of the screening, at the end, 4,000 patients out of PROfound, 69% had a HRR test success rate, and then out of them, 387 were, so it's 1/3 of the initial 4,000 that were then in the trial randomized. You've seen this before. That's the PROfound trial that led to the approval of olaparib in advanced mCRPC. And Javier just shown you the trial design cohort A, cohort B, and then the cohort A was BRCA1, 2, and or ATM. Cohort B was all other HRR mutations. Then the men were randomized 2-to-1 fashion to olaparib monotherapy or physician's choice. Baseline or backbone was always ADT. The primary endpoint was radiographic progression-free survival. Secondary endpoints, time to pain progression, but also survival, safety, and tolerability. This is a result. And you see, there's a huge difference, especially patients with germline HRR mutated, including BRCA2, are more likely to have poorer outcomes on standard therapy. You see the curves here compared to the non-carriers. And the time to progression in patients with mCRPC also is different. That's why looking at this result here, and you see statistically and I think clinically meaningful benefit in RPFS for olaparib curve. You see the curve, how slow it's going down compared to the other treatment choice, physician's choice, so the other NHT, ARBI, or ENSA. And this has translated in an overall survival benefit, as you can see on the right. So my take-home message is NHT treatment probably makes no sense in third and second line treatment. However, switching to PARP inhibitor, in this case olaparib, really prolongs overall survival and reduces progression here in the BRCA1, BRCA2, and ATM cohort. This, due to time limitations, I won't go into details because we only have TRITON2 published data, and we are awaiting the TRITON3 data, this larger phase 3 randomized controlled trial. But this is a trial looking at rucaparib in advanced mCRPC, and you see here also a lot of responding patients, and this led to approval of rucaparib in the United States. So here summarized for you the different approval status of PARP inhibitors in prostate cancer. On the left, you see olaparib as indicated in monotherapy in mCRPC, HRR mutated, progression on ENSA or ARBI, and also rucaparib, BRCA mCRPC progressed on AR-targeted therapy and additionally one taxane. So we'll see, depending on TRITON3 readout, if this label gets expanded or changed. In the European Union, olaparib has an EMA-approved indication, mCRPC, with a BRCA mutated situation, progressed on NHT. And as you see, this is like first-line mCRPC. So that's why I personally test the man when they are at the end of MHSPC and you have a feeling, you have a PSA rise again and schedule for imaging, then I think it's the best time to do the testing. So guidelines, practical guide, how to decide. And we have opportunities for olaparib and PARP inhibitors in mCRPC with the profound monotherapy, but also, and I will come to this within the next chapter of my talk, the PROPEL data. And here, a combination with abiraterone. I'll show you in a minute what this can mean in the future or how this might change our treatment algorithm. Summarized for here, the most recent EAU guideline recommendation and also NCCN recommendation, where in the US we have the additional approval for rucaparib, another PARP inhibitor for advanced mCRPC. So Europe and US olaparib approved for mCRPC with HRR mutated. So it's important to test. So my final saying, is it really important to test, ? Do we need to know? And that's a look into the future and the future combinations and what might happen. And we know from the 8 trial 8, which is called, but it's the Noel Clark publication in The Lancet Oncology in 2018, showing 35 decrease of risk in progression seen in the combination arm olaparib and abiraterone, here 13.8, compared to just giving abiraterone and placebo. So this was the hypothesis of larger phase 3 trials, which have been reported a couple of months ago at the ASCO GU meeting in San Francisco. The first I'm going to start with is a PROPEL trial. PROPEL phase 3 randomized large trial, first-line mCRPC indication, and then the men were randomized to olaparib plus abiraterone versus just abiraterone. So the classical mCRPC situation, no prior abiraterone allowed. However, docetaxel was allowed in MHSPC. The primary endpoint was radiographic progression-free survival, and key secondary endpoints, for example, is overall survival alpha controlled. This is to be important. No testing was performed before. It was done later on. And this is the PROPEL PFS and the median 8.2 improvement. This is, I think, huge. And the 34% reduction of risk of progression or death was noted and published by Fred Zard at the ASCO GU meeting. So very, very interesting data, which made us thought, how can this be in an untested population? For overall survival, it is still too early. So we really have to await further to really see, and it's a secondary endpoint. This trial wasn't powered on primary endpoint OS, but the curves you see are separating. Personally, I really want to see the signal here in the next years. Second trial, and apologize that I cannot cover all the details of the trial. It's more like a teaser within those 20 minutes, what we are going to expect, but you can see the ASCO presentation, you follow or you see the magnitude publication, which is about to be published. Another trial, magnitude trial, same indication, mCRPC here, up to 4 months prior, abiraterone was allowed, but in median, it was just 1.5 months, the patient that received it. And here they did testing, HRR positive, HRR biomarker positive, and then another PARP inhibitor. You hear it first time here in this talk, niraparib, combined with abiraterone compared to placebo, and abiraterone was tested. Also the same as PROPEL, radiographic progression-free survival by central review was a primary endpoint. Here, the design was biomarker stratified. And in the pre-testing, the biomarker negative group had a negative result. You see hazard ratio 0.09, so dramatic. So in this situation, niraparib and abiraterone showed no different compared to placebo and abiraterone. Of note, it's the HRR biomarker negative patients. This is what we would have expected. That's why PROPEL made a big surprise and caused a lot of ongoing discussion. Why is this happening? When looking at the HRR positive man, here you see again the great and dramatic difference in combining abiraterone with a PARP inhibitor, in this case niraparib. So we have combination olaparib, niraparib showing a remarkable RPFS benefit, and here also more than 6 months RPFS benefit for niraparib and abiraterone in the magnitude trial. So if we set this head to head, which surely we should never do, but we always do, the curves look separately, but still there are open questions. Why do we have this strong signal in PROPEL in this all-comer patient population? Why was it the dosage of niraparib? Was it the BRCAness caused by abiraterone? Was it there like theories of 4 pillows, the reasons of why this can be, or the synergy as proposed by Noel Clarke's 8 study on this phase 2 trial of abiraterone and combination with olaparib. So my take-home message, and then I have another slide after this take-home message. Take-home message: PROPEL has demonstrated that BRCA HRR mutated status testing is not necessary to identify patients who may derive benefit from olaparib and abiraterone in first-line mCRPC. This has to be debated. I think we find time later if this is really the case, but it could be a statement. I personally think molecular testing in prostate cancer from the point of mCRPC is still very important. It's clinically important. It's prognostically, as we have learned from Professor Puente's talk, for risk assessment purposes, and can and should, in my opinion, guide the treatment decision. However, we also know it is difficult to test, not easy, sometimes costly. So maybe an open, a broad label with a more open indication, with a combination, would help us all. So I think this might be even good if we get this label approved, or this combination approved, olaparib and abiraterone, or niraparib and abiraterone, in order to not to have to test, which I don't mean we should not test. So we are in worldwide, we have precision medicine for prostate cancer, and at least in the mCRPC setting, I think it is mandatory. We should not hide this for our patients. We need to educate our patients, work closely together with our pathologist or the ones that who does the test. So as promised, last picture, this is a view from Lugano, and little recommendation. In a couple of years, 2024, we have the APCC meeting again, very exciting, 120 world experts from all over the world discussing, and you're probably aware of all those experts here on the panel, led by Silke Gillison and Aurelius Omlin. And here, this is Noel Clark on stage, and he was discussing this topic, why the difference? And he had no answers. He had this for discussion, and this is why I bring it here. Different patient population, yes, of course, different trials. Different trial design, yes, also, of course. One is an all-comer, broad patient population. The other one is more a precision approach with biomarker positive and negative. Are PARP inhibitors all the same? We had let's say, a very intense discussion at the ASCO GU on Merat Ajawal and Tia Higano, where him asking her if olaparib and niraparib are the same. Surely not. They have different profile, and it would take another hour to really show the differences of, for example, just an idea, PARP trapping, which is different among the PARP inhibitors we have had and we have discussed. And the effect of prior abiraterone treatment, which was allowed in the magnitude trial. However, it was just a very sparse portion of patients, and they received it only in 1.5 months in medium. So what's the community saying when we ask the world experts? And I know Juan is also very active on Twitter, and I just had one survey at APCCC, and you see after one day we had more than 80 votes. And what do we do now? ABI and PARP inhibition. And here's what's the result. And the most of the people said await overall survival data and to decide. Then 34% really liked the HRR positive testing, and then only in magnitude, and 9% had all comers. But I think we have to revisit this question. And personally, for me, I think it's very interesting to have the combination approved also in an all-comer population, in order, if we come into hurdles with testing, don't find the right tissue, have problematic, Javier was educating us on somatic or germline mutations, which is different modes of testing and the expenses. So maybe it's a good way to look at. So at the end, just a short notice and thank to the sponsor for letting us have this webinar. I hand over to Juan, and thank you very much for your attention.
Thank you very much, Dr. Messenberger. We have seen already the basis, let's say, with Dr. Puente. Then we have seen what we have in the evidence for this approval. And now, after we use these new agents, let's see how can we tackle the toxicity and adverse effects with Dr. Javier Puente. Javier?
Oh, thank you so much, Juan. Again, thank you for inviting me, and congratulations, Axel, for your clear presentations with clear message at this point. So thank you so much. Well, my last talk in just 5-10 minutes is about the toxicity and safety profile with these PARP inhibitors, and how can we manage properly these kind of drugs. These are, again, my disclosures, and again, thank you, the European School of Urology and AstraZeneca for inviting me. I think that it is important to keep in mind that when we use a drug in any disease, in any given purpose, we will be more effective if we are able to properly manage the drug. And I think that we can try to achieve a better overall survival, delay progression, increase the tumor response without affecting quality of life, with a correct management of the drug. And this includes the correct dose, the correct side effect management, and the correct treatment duration. And all is try to maximize the effect of a drug in the setting, even in the metastatic prostate cancer. And this figure tried to summarize the substantial efficacy in several tumors that we have observed with the PARP inhibitors. And we know that we have approvals in breast cancer, in ovarian cancer, in pancreatic cancer, and also in prostate cancer. So we have a lot of data about the toxicity management of these PARP inhibitors. However, we are going to describe only the safety profile in patients with prostate cancer, but as you can see here, we have a lot of data coming from different trials in different scenarios and tumors. Well, this figure tried to summarize the toxicity profile of olaparib in the PROfound study. As Axel mentioned before, 387 patients were recruited in the trial, 256 were treated with olaparib, and 130 were treated with the control treatments. As you can see here in the slide, the incidence of adverse events grade 3 or higher was higher with olaparib than with the control treatment. And the most commonly side effects were anemia, nausea, fatigue, anorexia, diarrhea, and vomiting. As you can see here, the most frequently grade 3 or greater were included anemia and nausea, as you can see here in the slide. Something interesting is when these side effects occur. And the median time to onset of the first event occur in the first 3 months and typically resolve in the first 6 months. As you can see here, the median time to the first anemia, for example, is 1.9 months. So it's occur in the first 2 months. The early toxicity that we can observe with olaparib is nausea, with 0.5 months to occur the first event. But the majority of the event will resolve with a median time around 4 months, as you can see here in the slide. And many of them will disappear in a period of 6 months. This is the most commonly adverse event that were described with the olaparib, and many of them will be treated with supported treatments, with dose interruptions and dose reductions. These data coming from a Zoom analysis published in ESMO 2021. And as you can see here, majority of patients that suffer anemia were treated with supportive therapy, for example, with blood transfusion. And 25% of all patients that suffer anemia will treated with dose interruptions, 60% with dose reductions, and 7% will discontinue it due to anemia, where we were treated with olaparib. The rest of the toxicity of adverse events were infrequent to lead at dose interruptions, dose reductions, or discontinuity, as you can see in the slide, is less common to introduce the drug because of the nausea, anorexia, and fatigue. And the most commonly side effect that you will be focused in the anemia and the hematological toxicity. Something interesting is how can you manage this anemia, or what is the increase of risk of anemia in patients with high tumor burden in bone metastases and treated before with chemotherapy that could be influencing the myelosuppression function. As you can see here, it does not appear to be an increase of risk of anemia with olaparib in patients with high tumor burden with more than 10 bone mets and patients that have been previously received docetaxel. Most of half of patients with anemia have more than one blood transfusion, and 11% of the patients included in the trial receive erythropoiesis-stimulating agent. And this is something to be interesting. When you suffer a patient with anemia, you can manage them with supportive treatment with blood transfusion or with these erythropoiesis-stimulating agents. Something interesting to be into account is that it has been described that venous thromboemboliums occur in 7% of the olaparib patients treated in the trial, and pulmonary embolims occur in 4% of the patients treated with olaparib. The onset to suffer this toxicity is 1.8 months, so it's the first 2 months of treatment, and all of them was grade 3 and lead to dose interruptions. However, the evidence from PROfound study is insufficient to confirm or to refute a causal association between the pulmonary emboliums and olaparib because of the risk of this toxicity even in patients with metastatic castration-resistant prostate cancer. This slide are coming from the initial visit of the trial that we performed in our hospital several years ago, because we were involved in the PROfound study. And something interesting that you can take into account is the creatinine clearance, because patients are currently treated, most of them with 300 milligrams twice daily, but in patients with a creatinine clearance between 31 and 50 milliliters per minute, we recommend those reductions to 200 milligrams twice daily. We don't have any data in patients with cerebral renal impairment, less than 30 milliliters per minute, and this is something to be cautioned. This table summarizes what is the most interesting toxicity, but in general, patients that suffer grade 3 toxicities is necessary to interrupt the drug, to recover the patient, and after that, to initiate it with a level, less 1 level, with 250, or in the second occur of toxicity, 200 milligrams twice daily. So we have 300, 250, and 200 for different level of dosification. Another PARP inhibitor have described the toxicity. In a quick review, you can see here this side effects with rucaparib, and again, asthenia, anemia, and thrombocytopenia is the more frequently adverse event, so to be cautioned about the medullary toxicities. You can see here the result with the talazoparib, a new PARP inhibitor that we are currently performing clinical trials, and again, the majority of the toxicity are related to the anemia, thrombocytopenia, neutropenia, nausea, and anorexia. More than half of the patients suffer any toxicity adverse event where you are treating these patients with PARP inhibitors. Again, in this case with talazoparib, the most early toxicity is the thrombocytopenia, with a median time to the first thrombocytopenia is around 17 days. So it is very important when you schedule the visit of the patients that you visit the patients in day 1, day 15, day 28, in the first 2 or 3 cycles to identify correctly this toxicity, try to interrupt the treatment, include the supportive care, and after that, to resume the day with a similar dose or with a level 1 of dosification. This figure tried to, well, describe the toxicity again during the first cycle, 2 cycles, and after that, the majority of the patients are under treatment without any grade 3 or a greater event. So the take-home message are that in the PROfound study, the most commonly adverse event were anemia, nausea, anorexia, and fatigue. More than 30% of the patients could suffer this toxicity. This toxicity typically occur in the first 3 months of treatment and were generally manageable with supportive care, dose interruptions, and dose reductions. You keep in mind 300 trace mail daily, 250 and 200, according with the difference rate of toxicity. Similar toxicity has been observed with another PARP inhibitor, with niraparib, with talazoparib, the similar toxicities. And this is very important to keep in mind that the adverse event and the early identifications is crucial for no deterioration of quality of life and a correct management of this drug. Again, thank you to the support to AstraZeneca and the European School of Urology. So, Juan, It's your turn.
Thank you very much. So once again, to the two speakers for the brilliant overview on PARP's inhibitors in advanced prostate cancer. Let's give a couple of minutes to the people to ask through the chat box, and by the time while I read the questions, I will give you one question. Let's say that you are the EMA, you are the European Medical Agency, both of you. And I said EMA because the FDA probably is too lax. But let's say that you are the EMA. What do you need, or what would you wait for in order to approve niraparib and olaparib? Is radiological progression-free survival a surrogate for clinical benefit and is enough for you? Or would you wait until overall survival data? Or can you rely in any other secondary points from the studies in order to approve this novel indication as a first line in castration-resistant prostate cancer?
Well, it's a good question, Juan. I prefer to be the EMA and not the Spanish government because we have a lot of problems here with the approval of the drugs. However, I think that obviously the first line in metastatic castration-resistant prostate is different from the second and third lines. Obviously, at this moment, we have a lot of background and a rationale for use these PARP inhibitors in patients that they are suffering these DNA repair genes alterations. I think that biologically, I think that I'm very comfortable using these combinations in patients with alterations of DNA repair, even in the first line with only PFS, because obviously these patients have a poor outcomes, a worse outcomes, and maybe in the future we will show a benefit in overall survival. So at the first time, at this moment, if I'm the EMA, I approve the combinations in patients with alterations in BRCA alterations, at least at this moment. The question is this something that will offer to all patients, all corners, independently of the DNA repair alterations or not? I think that according with the survey of Axel, I think that I still the overall survival metadata, because obviously we have other data coming from another trial. For example, with the potential trial with the use of ipatasertib, and we know that patients that we have identified by NGS having a PET and loss have a very good results in terms of PFS, 20 months versus 40 months, and a hazard ratio of 3.5. but without any impact in overall survival. And the data is awaiting for the overall survival. So I think that at this moment, just for BRCA tumors, independently of the, I think PFS is fantastic for my side, but for the rest of the patients, I will stay waiting for the overall survival. I don't know what is the opinion for Axel.
Well, 3 comments. I think the EMA and the FDA should learn from each other. The EMA should not be that strict and the FDA should not be that loose. And maybe, for example, FDA approved olaparib in BRCA1, whereas in the subgroup, we don't really see a strong signal. So it's something which EMA didn't do. So I think a mixture would be an idea. Secondly, I think I would need to see the full publications. So far, we haven't seen them for PROPEL magnitude for both. So I want to await full publication, seeing the full spectrum and not just a 10-minute talk at ASCO GU flanked by some slides. This would be important when I answer Juan's question if I would be EMA. Thirdly, I think the landscape has dramatically changed. We don't have this MCRPC as it was, like patient rising PSA giving ADT, and then what's next? We have mostly doublet combination like apalutamide and ADT, enzalutamide and ADT, and even now we have triplets. We have seen Arasense, we have P-Stater with a combination of a triplet, docetaxel, darolutamide, abiraterone. So the landscape is changing. So what's next? So I think an open label for PARP inhibitor, and that's my personal take on, would be good for us treating uro-oncologists to have the possibility, and then we have to wait upon like side effects, the value and the response, and we see it easy. And we also know that about 50% of the men don't respond, even they are BRCA positive, to a PARP inhibitor. we have failures even in BRCA1 and BRCA2 positive men. So I think we need to really always have to wait the toxicity and the efficacy to in this stage and rigorous or somehow well-scheduled restaging and PSA. And then we have other options. We have carboxytaxel, we have radium, we have lutetium evolving therapy after vision trials. So a lot of about to embark to what we have in MCRPC. So this would be my take home to a question. Sorry, answering rather long. Thanks.
No problem. We have a question from the audience regarding if you have any experience or you have read about difference, and in response regarding somatic and germline mutations on response with the treatment. Is there any difference depending on from where comes the mutation?
Well, I think that sometimes it has been suggested that will be any difference in activity. Obviously, patients that are having the germline mutations have a poor outcomes in any stage of the disease that we have mentioned before. Even in patients that have been treated with the same treatments, prostatectomy or radiation therapy, or even in the same kind of patients that are having a metastatic castration-resistant prostate cancer, those patients have poor prognosis. But in general, in some recent meta-analysis, there is no difference in the activity, at least when you combine all the data coming from different trials. However, these trials has been conducted in different diseases, not only in prostate cancer, but also in ovarian cancer, breast cancer. And when you mix those patients with germline mutations and somatic mutations, there are similar activity with this kind of drugs. This is completely different for patients that we have a biallelic compared with monoallelic mutations, because we have different results with different drugs in this setting, and we will be associated with a PARP inhibitor sensitivity. So it is completely different.
Just to add a small comment on that, I think it has an implication on the families of the germline mutated man. So I think here genetic counseling really makes sense to consult the relatives.
Okay. I have one question for probably both of you. We know that these germline mutations and DNA repair genes alteration, they can be together. I mean, because a patient have a BRCA doesn't mean that cannot have a PTEN loss, let's say, right? You can have many alterations in just one patient. And let's say in the ideal future, every patient with advanced prostate cancer will have a landscape or all their genes mutations. And I know, Javier, that you're a really fan of PTEN loss, and I know that you have been very involved in this. How or what are you going to do in the future? How you're going to make your decisions in terms of if you have a patient, for example, with BRCA and also PTEN, because PTEN is common. You said probably half of patients with castration-resistant prostate cancer have PTEN loss.
Yeah.
How would you make your decision on which one of the new agents you will use, or probably you will use olaparib with abiraterone, because we know olaparib and abiraterone it's work for both, for alterations or not.
Well,
how are you going to do your decisions in the future in this personalized medicine world, let's say?
Well, first of all, I think that ideally, fortunately, the complexity is increased a lot. And this is something great, because obviously we can individualize the treatment of patients with this disease. And I think that it's going to be more interesting, like our colleagues that they are treating lung cancer, that they are looking for a small subgroup of patients and treating it individually with a very high rate of success. I think that obviously the future is coming, and the technology will support us to make the correct decisions in the future. Obviously, we have a lot of information coming, the different analysis of tumor samples. Obviously, liquid biopsy will help us to monitoring the treatments that we are currently treated, because obviously this disease are dynamics, And obviously, we have a truncal alterations at the beginning. For example, in patients with BRCA mutations at the beginning with the germline alterations, obviously these treatments will be on the top of the treatment decision tree. I think so, because the impact in the evolution of this disease will be very important. So I think that some alterations will be in the top of the decision tree. In another, alterations will appear in the evolution of the prostate cancer. So we will learn to monitor these alterations in the future and making the decision based on the results of these alterations that they are common in the history of this disease. But at this moment, it's a little complicated to compare different alterations. However, if I have to decide today, I prioritize the BRCA alterations and the MSI alterations in the treatment decision of patients. In the future, we will see.
Axel, any thoughts about this?
Well, maybe to add on, because I can otherwise only echo what my colleague just said. I mean, you are asking also on the differences on PARP inhibitors, and worldwide we have in different indications, I think about 5 approved. And there is a difference surely in dosage and toxicity, and also in this PARP trapping potency, which we would probably also need another webinar to really go in detail in that, but we all know like efficacy, this could be different. And the PARP trapping activity is increased from beginning veliparib, then rucaparib, then olaparib in the middle, and I think then it's NIRA. And the last one is talazoparib, where we have the Talabro 2 and 3 trials running right now, and a combination with enzalutamide. So the landscape is not quiet there. So I think we really need to await future data, future combinations and differences to really understand the differences among the PARP inhibitors in this indication, advanced metastatic prostate cancer. Thank you.
We have 2 questions from the Q&As. Let's try to answer them before we close the webinars. The first one probably is already answered in the lectures, but we can repeat it. With which one of the agents has been suggested to be active in patients not harboring DNA repair mutations? Which one of the agents that we have discussed, talazoparib, niraparib, olaparib, or rucaparib?
Axel, do you want to answer the question?
Yeah, I
think that
we
have mentioned before.
Yeah, I think this is what has been answered.
Yeah.
We don't have head-to-head direct comparison, but there might be differences with the aforementioned and the veliparib as a 5th one. So I think, but here olaparib and also talazo niraparib play like a dominant role with the highest PARP trapping activity.
And the last question is with the approval of the PARPs inhibitor, only BRCA1 and 2 mutations means that we have to do 10 or more tests to benefit one patient. Will that be cost effective to do tests to so many patients with a marginal benefit, let's say?
Maybe I can start. I think it is always well invested for getting precision medicine, and uro-oncology is expensive, especially the medical therapy, and compared to the monthly price of most drugs, which range from 2,000 or ADT 400 euros up to 16,000 in combination and triplet therapy. This is like a piece of cake in a very small portion. And I think here you have the chance to really have precision therapy. And depending where you do it, if you send it out for like commercial testing, this is always more expensive, but we have a good collaboration with our pathologist, Sven Perner, who is just doing it in a homemade test, approved, validated test. So I think depending on the panel, what you use, you can have pricelier conditions. And I think it's well invested, my take-home message.
Yeah, only one comment. I think that this kind of analysis will be integrated in another way to do the things in the hospitals, because obviously prostate cancer is not the only tumor, and I think that this is something that we will do in the future in urothelial carcinoma, nowadays in lung cancer, in breast cancer. So I think that this kind of analysis will be integrated in these next generation sequencing platforms. And obviously, if we perform this analysis in many, many patients, the low cost will be lower and lower, because obviously 10 years ago, performing this kind of analysis was very, very expensive. And today this dramatically dropped out. And this is something very important for patients. And I think that in the future will be cheaper than today. I hopefully think that.
Well, thank you very much, Dr. Messenburger and Dr. Puente. I really, really appreciate that you were here together with us today. I think also that at the same time, that is very important, as we have been in this webinar, to keep working together, oncologists and urologists, just in order to tackle a disease that we should do together and work together with the patients. I would like to remind to the audience that the recording of this webinar will be available in the European School of Urology YouTube channel in 2 days. And with this, I close the webinar. Once again, thank you very much and keep in touch. Bye-bye.
Bye-bye.
Take care.
Bye. Thank you.
Bye-bye.